It's 2 in the morning at a big city hospital. The lobby is quiet. Walk the wards and you'll pass darkened rooms, made beds, nobody in them. And yet, tonight, this hospital is completely full. The emergency room is holding patients it has nowhere to send. How can a building with this many empty rooms have no room left? That's not a paradox, it's a design. Start with a real night. January 11th, 2024. Massachusetts General Hospital, one of the best resourced hospitals on Earth. That day, 103 patients were stuck boarding in the emergency department, waiting for a bed upstairs that nobody could open. Over the previous year, patients spent 381,000 hours boarding in that ER. The hospital declared, in its own words, a capacity disaster, not a war zone, not an underfunded safety net clinic. Mass General. So here's the question, asked like an operator. Not why is a hospital busy? Why is it structurally out of room, even when you can see empty rooms? The answer is 4 things those empty rooms hide: what a hospital bed actually is, a piece of math about the number 85, why the real traffic jam is at the exit and not the entrance, and why the money quietly makes all of it worse. First, the number that starts the whole thing. The average American hospital doesn't run at 100%. It runs around 75, up from about 64 before the pandemic. Now that's an average. A quiet rural hospital really can be half empty, but the big, busy hospitals most of us actually end up in live much closer to the edge. Hold on to that 75%. In a minute, I'll show you why. For them, it already means full. Because a hospital bed is not what you think it is. When you picture a bed, you picture furniture, a room, a mattress, a monitor. But in operations, that empty room down the hall doesn't count as a bed unless there's a nurse and a team assigned to staff it. A licensed bed is a room. A staffed bed is a room with a nurse behind it. Only the second kind can take a patient. A bed without a nurse is not a bed. It's a storage room with a mattress in it. And this is where the shortage actually came from. When researchers looked at why occupancy jumped, it wasn't a flood of new patients. It was a 16% cut in the number of staffed beds compared with before the pandemic. The buildings didn't shrink. The staffing did. Hospitals closed beds they couldn't staff, and the beds that were left filled up. How short was the staffing? At the peak, in 2022, nearly 1 in 6 hospital nursing jobs sat empty, a 17% vacancy rate. When you can't staff the nurses, you can't open the beds. This is why California was the first state, and still has the strictest rules, for capping how many patients a single nurse can be handed. The nurse, not the building, is the real bottleneck. Now the math nobody explains. It's tempting to think a hospital only runs out of beds at 100%. But patients don't arrive politely, one out as one comes in. They arrive at random in clusters. Model that, and what matters is your average occupancy. Keep the average below about 85%, and the odds of a patient finding no open bed stay near 0. Let the average drift up to 90, and it's around 1%. Push it toward 100, and it's nearly 1 in 5. 85% isn't where you're full. It's the line where crowding stops being rare and starts being routine. The researchers put it plainly. Above roughly 85% occupancy, a hospital can expect regular bed shortages and periodic crises. Now go back to that 75% average, because an average hides its bad nights. A hospital that sits around 75 most of the year still spikes past 85 on a flu week, on a Monday after a bad crash. And every time it does, it's in the zone where the math turns against it. And the buffer that used to absorb those bad nights has been shrinking for 60 years. In 1960, the United States had about 9 hospital beds for every 1,000 people. By 2022, it was under 3, a 70% drop per person. Some of that is good medicine. Surgeries that once meant a week in the hospital are now outpatient. But it also means the shock absorber is a lot thinner than it was. There's not much empty road left to give. So the beds are fewer, and 85% is the real ceiling. Now watch the flow, because a hospital is really a building with 2 doors. Patients come in one and leave through the other. When it clogs, the instinct is to blame the entrance. More often than not, it's the exit. Start at the entrance. When there's no bed upstairs, the emergency room becomes a parking lot. Patients board, sometimes for days, waiting for a room. And here's the operational absurdity. One 2024 study measured it. Holding a patient boarding in the ER ran about $1,856 a day, nearly double the roughly $993 it cost to care for that same patient in an actual inpatient bed. Worse care, higher cost. That's what a clogged hospital does. And this isn't rare. In the winter of 2024, more than a third of admitted emergency patients waited over 4 hours for a bed. About 1 in 20 waited more than a full day, 24 hours boarding in the ER, admitted to a hospital with rooms it couldn't open. But the entrance is the symptom. The real jam is the exit. Picture a patient who's medically ready to go home. Treatment finished, cleared to leave. In a working system, that bed frees up in an hour. Instead, they wait. There's no open bed at the skilled nursing facility, or the insurer hasn't authorized the next step. Or there's no safe way to get them home. The patient is done, the bed is still occupied. And every one of those is a staffed bed that can't take the patient boarding down in the ER. And that exit has been getting slower. By 2022, the average hospital stay ran about 19% longer than before the pandemic, and nearly a quarter longer for patients who needed a nursing home or rehab bed next. The hospital's own association pins much of that on discharge delays, people who were ready to leave and couldn't. Every extra day at the exit is a day that bed can't be used at the entrance. Here's the twist that surprises even hospital leaders. A lot of the chaos isn't the emergencies at all. Random ER arrivals are surprisingly predictable in bulk. You can staff for them. Some of the wildest swings come from the part hospitals actually control, the elective surgery schedule packed into certain days and certain mornings. When the planned surge and the random surge land on the same Tuesday, the hospital gridlocks, which means a lot of "we're full" isn't fate, it's a calendar. So why don't hospitals just keep a cushion of empty staffed beds, ready for the bad nights? Because empty beds lose money. The median hospital ran on a 4.9% operating margin last year, and about 40% were in the red. When your margin is that thin, an idle staffed bed doesn't feel like safety. It feels like waste. So the financial pressure points the wrong way. Staff lean, run close to full, and treat spare capacity as a cost, which is precisely the state where the math says you break. But that also means the fix doesn't always require a single new bed. When hospitals smooth the schedule, spreading elective surgeries evenly instead of cramming them, hidden capacity reappears. One children's hospital freed up over $100 million a year of capacity in the beds it already had. Another credited smoothing with around 40 fewer deaths and $9 million in a single year. These are the hospital's own reported results. But the pattern is consistent. Same building, same staff. They just stopped colliding with themselves. So put it together. A busy hospital that looks half empty is full because a bed is a nurse, not a room. Because 85%, not 100, is where the math breaks. Because the exit is clogged with patients who are ready to leave, and because the money punishes keeping any slack. Always full isn't bad luck, and it usually isn't greed. It's the equilibrium a system settles into when you starve its buffer and pay it to run hot. The empty room you can see is real. The nurse, the discharge, and the margin that would let someone lie in it. Those are the parts you can't. If you want the operator's view of how healthcare actually runs, the systems behind the headlines, in plain English, the breakdowns are at shanewelter.com/free. Next question in this series. Why do you wait 4 hours in an emergency room that looks half empty? Same building, same paradox, different door.